I'll show you this thing. It's a so-called quality of life measure, a very short one. It's called the EQ5D, widely used in health studies. And it's also called a PROM. Now, a PROM is not a ballroom dancing, or it's not music by the BBC. It's not none of that. PROM is a patient-reported outcome measure. It's a mouthful, so PROM is easier for me to say in the long term, but a PROM is a patient-reported outcome measure. Now, what's behind the PROM story? PROMs is a number of questionnaires, very different questionnaires that measure health, status, well-being, quality of life. It's a range of mood situations and so on. They tend to be of different length, and they have been developed for very different purposes. Now, PROMs are subjective measures because they're filled in by the person, so it's seen as a good thing. The person can fill it out, you get some view perspective from the person, and you're not just counting side effects, death, or complications as a result of a treatment. And so you have some subjective, some well-being measures. Now, in England, the NHS has rolled out PROMs to measure routinely, and it's mandatory for all NHS organizations to use these measures to assess the treatments in terms of the patient-reported outcomes. Mostly used for knee and hip replacements, varicose veins, so acute surgical procedures, not so much for chronic procedures. But there has been a pilot around chronic obstructive pulmonary disease, chronic lung disease. Now in Scotland, it hasn't happened yet, and we were curious. We asked just one question. So it's nice to have these questionnaires, but what if you cannot read? What if you have a learning disability? Okay? What then? 1 in 5 people in Scotland cannot find their own name in the phone book. Struggle with literacy. So, what are we saying? If we're using these measures, do we care about these people? So then we had a 2-phase study. We looked at what are these measures like that one that are proposed to be routinely used in healthcare practice, and have they been developed and tested for people with low literacy or learning disabilities? And I guess you can guess the answer? No? Not a single one has been tested or used with people with learning disabilities or low literacy. So then we went to the second stage of our study and took some of these measures and took them to people with learning disabilities and asked them, so what do you think? Could you make sense of these? And I said, no, this is confusing the way it's laid out. I don't understand what people want from me. I don't understand I cannot even read some of them because they were small print. That's big print. They also said, if I have to fill this out in hospital, I wouldn't want to do that because there's no privacy. If I have to fill it out in the GP practice, I wouldn't want to do that because I feel stressed. Or I have bad experiences from the past with filling forms. Because last time I filled forms, I made mistakes and I was threatened to lose my benefits, my social security benefits. So I need assistance, I need other formats, I need a different way of having my voice heard. So what we're saying basically, if we're considering using these measures, we're excluding people from data collection, from developing safe and effective practices that they might benefit from, and ultimately from quality improvement. And that's a substantial proportion of the population, if you think cumulatively. We looked at people with learning disability and low literacy. Think about people with dementia, who might, over time, develop difficulties understanding, interacting with these measures. Think about people with traumatic brain injuries, who have a shortened attention span potentially, people with psychiatric disabilities. So I would say, I make a bold statement here, people with disabilities are dying preventable deaths. And we know that. We know that from various reports. Well, we know that also from the invisibility of people and the data collection methods that we have. And we know that people, and we just talked about that I think before the talk, about people not getting the right health education, health promotion that's accessible to them. They don't get the same health advice, the same health counseling, they don't get the same primary preventive services and care in the general population. There's something I heard recently, also this term mentioned to me, this diagnostic overshadowing. You have a spinal cord injury, you have cerebral palsy, you have a stroke, and that overshadows everything else in your life when you see a doctor. If you access a health professional, all they see is a spinal injury, all they see is stroke, all they see the cerebral palsy. They don't see there's a human being who could get cancer, who might drink a lot, who might smoke a lot, and who might have sex, right? Because that's ruled out, so that's not very visible. So what about sexual behavior counseling, drug and alcohol use counseling, anti-smoking counseling? Assumptions are made that this doesn't apply to people with disabilities. And yet we know from the few statistics that we have as a group, as an aggregate group, they have the same health risks as the rest of the population. They might be even less likely to exercise, they might be as likely to smoke and drink alcohol, and they might be more likely to carry excess weight. So lack of accessible environments, fitness centers and mobility environments. We did some work recently in that as well. So if they cannot get their primary preventive services, then what are the problems involved? And I think Ed has a card now. Yep.
The doctor disregarded normal health concerns as not only secondary to my obvious disability, but unimportant to address entirely. I have avoided GYN care for years as I need help to get on the GYN table for the examination. The mammogram machine wouldn't work with my wheelchair because it couldn't be positioned properly, and I don't get preventative GYN exams because I cannot find a doctor who does these exams and takes Medicaid who also has an accessible exam table.
Thank you. So we haven't replicated the study here, but I assume some of the issues, some of the challenges are probably quite similar. How many GPs do you know who have wheelchair accessible scales? How much health information is accessible and available in alternative formats? It's very likely to be available in other languages, but is it available in Braille? Is it available in auditory formats? Do you have the assistance in the provider office? What we found is often time constraints of GPs to provide services to people with disabilities because they required a little bit of extra time, they required assistance, they required transfer time, safe transfer time to get in and off the examination table. So there were a range of barriers that we found in terms of the knowledge, the attitudes, but also mostly around the practicalities. Some of them were around the environment, the buildings, facilities, the access to buildings, and the equipment being used in those buildings. But very often also disillusionment on the side of the service users because they had experienced that nobody cared about those issues. They were not aware of those. Or they lost the motivation to really seek these services because after years and years of going and seeing the doctor and requesting other things and not being listened to, they lost the motivation and engagement to request these services.